So one of the bigger things that follows on from the approval in the UK of adjuvant atezolizumab is where we're going with other perioperative treatments. We had a recent press release from MSD about the PEARLS trial. This was an adjuvant trial in which patients with stage 1 to stage 3 non-small cell lung cancer that was resected, whether they had adjuvant chemotherapy or not, were randomized to adjuvant pembrolizumab or not. And again, there seems to be a DFS benefit. Now, we're waiting for this data to be presented and drill down on the details of this. But this may offer a different group of patients that are not covered with adjuvant atezolizumab receiving adjuvant immunotherapy in the future. We'll have to wait and see the data, but that clearly is really important. The other thing that's really important is the neoadjuvant trial CheckMate 816, in which patients were randomized to receive either neoadjuvant chemotherapy or chemo IO, and these patients had a benefit in terms of the downstaging, the pathological CR rate with neoadjuvant IO-based treatment, and it was markedly higher than chemotherapy alone. Now, that trial has followed up with disease-free survival and has, again, a press release reporting a disease-free survival benefit. Again, we're waiting for this data, and perhaps this may show that for some patients, neoadjuvant IO-based treatment is better than primary surgery. We already have some potential, a suggestion that neoadjuvant may be better for stage 3 resectable lung cancer from the NADIM trial. Dr. Provencio discussed this at the BTOG meeting. And I think, where we're looking at is that for PD-L1, at least strongly positive non-small cell lung cancer that's been resected, adjuvant IO currently with atezolizumab seems to be standard of care. Perhaps with stage 3, we may be moving to neoadjuvant chemo IO with a view to adjuvant IO consolidation, as perhaps with other stages would be moving to upfront surgery followed by adjuvant IO, or perhaps neoadjuvant IO followed by surgery. There's a great set of flux at the moment, but one thing is very clear is that surgery by itself and adjuvant chemotherapy by itself isn't necessarily all that patients need. They will probably need IO. What is the magnitude of that benefit? That will be determined by the PD-L1 status, I'm sure. And whether we give it adjuvant or neoadjuvant will really be borne out by the data in due course. So there's a lot of flux at the moment, but it will settle down over the course of the next year or so. Very exciting for our patients with operable disease, and I'm really delighted that patients in the UK seem to be getting access in a rapid manner thus far, at least with the atezolizumab approval.